Live on YouTube. That's where the majority of the people really watches. Live on YouTube. That's where the majority of the people. One more thing. It's boring stuff. I'm just moving code right now. Otherwise, I'd share the screen. Okay. Okay, we're ready to go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett broadcasting from Miami Beach. We're honored with the televising of Walter Dandy Neurosurgical Club with Mazen Samaha, a neurosurgeon from Jordan. The proceedings are going to be moderated by Nima Sadiq, neurosurgery resident, I believe, and she'll introduce herself as well as a doctor. Thank you. Okay, Nima, it's all yours.
Thank you so much, Dr. John. Hello, everyone. I hope you're having a good day. It's Nima Sadiq. I am a Sudanese physician and I am the scientific administrator at Dandy Yemen. We're very happy to have you with us today. Please, in the chat, tell us your name, your medical background, where are you watching us from? And with no further ado, let me introduce Dr. Mazen Samaha. He is a consultant neurosurgeon. He received his board certification from the Jordan Board Certified. He's specialist in minimally invasive and endoscopic spine surgery. He's a member of the Jordanian Association of the Brain and the Nerve Surgeons. And he's going to present for us stereotaxy for movement disorder. We're very excited for that, Dr. Mazen. The floor is all yours.
So good morning, good evening. I don't know at which part of the world you are, so I would salute all of you. First of all, I would love and thank your perfect cooperation, Dr. John, Dr. Naima, and Dr. Ahmed. I don't know if he's following us. I'm very proud that for bringing up this committee, the Walter Dandy Committee, and the Neurosurgical Club. The Yemeni people are very good and perfect in making every challenge, turning it in a potential moment. So thank you again. We have our condolences to the Professor Yazergel that he passed 1 week ago, passed away. He was a big influencer on neurosurgical domain. So to start, again, I am Mazen Samaha. I am in Amman, Jordan, and I do stereotaxy for movement disorder. That will be our talk today. So by definition, what is stereotaxy? It's a concept of using a 3D coordinate to find and localize a specific point in the space. Like in our job, it will be the space is the brain. By using a 3D imaging like MRI scan to create a detailed brain map. Again, we have to localize and target the brain areas, and we always use this approach in taking biopsies, implanting devices like shunting and other devices, and Umayya reservoir in clinical angioma, or to deliver radiation like in the gamma knife radiosurgery. The mainstay of this approach is to preserve and minimize tissue destruction. What tools we have to get in our operating room? Of course, since we are targeting small nuclei and centers like globus pallidus, subthalamic, and or the basal ganglia targets. We have to get a very good imaging. So we are always struggling and fighting with the radiation or the radiology technicians to obtain very good images. Of course, we have to get a stereotactic frame and planning software and other accessories like if you are going for the radio frequency device, DBS, MER, and other implantables. So there are two categories in the movement disorder, either hypokinetic in Parkinson's disease or hyperkinetic, like dystonia, chorea, tremor, ataxia, and Tourette disease. As we know, what is the main? We don't know actually the cause of most of the movement disorder diseases like Parkinson's disease, but we have some hypotheses, and we all know that.
Dr. Mazen, I'm sorry for the interruption, but it seems that your presentation is not visible.
Do you see any slide now?
Not yet.
Do you see the camera?
Yeah, the camera is on.
I'm sorry, I was promoting.
So was it from the first of lecture? Was it missing or just now?
Yeah, it was the beginning of the lecture. I thought you did not start yet. That's why
Yeah,
I
we can
did.
start again. We can start again.
So I
Yeah,
will
no.
reset.
I'm
okay,
sorry, I was distracted by promoting. I'm sorry. Okay, yeah, I'll start from anew. That was my fault. Sorry.
Yeah. Thank you, Dr. Mazen. That's better. We can see the screen.
So we'll start again. So you see now, right?
Yeah, it's invisible. Thank you so much.
Okay.
Yeah,
So
I apologize.
it's okay. So again, by definition, what do you mean by stereotaxy? So it's a concept of using a 3D coordinate system to find and localize a specific point in the brain or the space by using imaging like MRI, 3D imaging to localize and target certain brain areas for either biopsies, to implant devices like shunting or catheters or electrodes, or to deliver a radiation like the gamma knife and the cyber knife and other devices. So the mainstay of this approach is to preserve and minimize tissue destruction. What tools we have to get in our pocket? So since we are targeting small and eloquent areas like the basal ganglia and other targets, we have to get the perfect imaging. So we are always struggling with the radiology technicians to obtain a very good and high definition imaging. Of course, we have to get a stereotactic frame, a planning software, and other accessories like the RV radio frequency device, DBS, MER, and other implantables. So for the movement disorder, there are two categories. So either hypokinetic like Parkinson's disease or hyperkinetic like dystonia, chorea, tremor, ataxia, and Tourette disease. Again, what is the pathophysiology of Parkinson's disease, let's say, because it's the model or most common disease of the movement disorder. So we always know that there is a deficit in dopamine, which is an inhibitory, mostly inhibitory neurotransmitter in the movement disorder diseases. So in 1980 until 1990, there was a Berman studied two science in my clinic studied the Parkinson's disease with primate model. They just discovered that there is a thalamocortical disinhibition due to the loss of dopamine neurotransmitter. So Benabid, he's a French-Algerian neurosurgeon, started to work on this model, and he discovered that a high-frequency electrical stimulation creates a temporary reversible lesioning in this area and to reverse those symptoms. So he did his first DBS in the mid-80s for Parkinson's disease. He implanted the first electrode in the thalamus to control the tremor of Parkinson's disease, and it worked very well. So it helped us to usher this approach and to do the surgeries. So our targets for most of the movement disorder diseases. So we target the posterior ventral GPI, anterior medial GPI, subthalamic nucleus, hypothalamus, and other targets. So regarding targeting of the basal ganglia nuclei, there are either direct targeting or indirect targeting. By direct targeting, we mean that we have to visualize our target and put our coordinates according to the anatomical visualization of the target. This is a very well-known line. You can see the mouse scrolling. Do you see it? Do you see the yellow line? This is called Bijani lines. He's a Lebanese neurologist. He was first describing this approach to target the subthalamic nucleus in a direct way. So first of all, we draw a line in the most anterior part of the retinal nucleus. Then we do another line on the most medial part of the thalamic nucleus. We take the cross section of them. We go 2 millimeters laterally. This is the best target to implant our electrodes in the subthalamic nucleus to control both the tremor and rigidity in Parkinson's disease. See the posterior ventral part of the subthalamic nucleus. Do you see my mouse moving, or so I can? Do you see it or not?
Yeah, it is visible, Dr. Mazen.
Okay, cool. Yeah, thank you. So regarding the indirect targeting, we go for the Schaltenbrand and Barren atlas. This is an atlas that defines and localizes every basal ganglia target according to the ACBC line. So first of all, we localize anterior commissure and posterior commissure, and we put our targets X, Y, and Z like you see here, 3 millimeter posterior, caudal, and lateral. So those are the targeting landmarks for most of the used basal ganglia targeting for most of the movement disorder. So what diseases we treat or we control with the DBS? So we do DBS for Parkinson's disease, for tremor, for most of the tremor disease like essential traumatic or multiple sclerosis. We do for dystonia, Tourette syndrome, OCD, and epilepsy. And in the upcoming future, I saw many articles and many studies that will be promising doing DBS for Alzheimer's disease, also for vegetative states and depression, cluster headache, chorea, and Huntington disease. This patient he is 47 years old. He has severe rigidity. It's a disabling rigidity. But what happens if he took the dopamine, carbidopa, levodopa? On the other side of the video, he has a dyskinesia, which is a severe movement disorder and drug-induced dopamine, a dyskinesia-induced dopamine. So if he took a half tablet of the dopamine, look what happens to him on the right side video. He started to have a dyskinesia. So he's stuck between the rigidity and the side effect of the medication. So he had no other way. So after consulting him, we decided to do a deep brain stimulation for this guy. So for Parkinson's disease, we have two targets, either subthalamic nucleus or globus pallidus internus. And we choose our targets according to the patient's symptoms, because this patient has dyskinesia. If we implant our DBS in subthalamic nucleus, he will have a very irritable dyskinesia. So we target his globus pallidus internus, the posterior ventral part of it, as you can see on the coronal view. We always like to check. This is the optic tract, as you can see it on both sides. We have to preserve it. We have to target, to implant our electrodes away from the optic tract, and you can see this triangular GPI on both the axial and the coronal view. So we did the surgery for him.
يلا قوم امشي يا المشي يمين
This
شمال.
is the first time we activated his device. Look, his rigidity is doing well. This was week after the surgery. We always activate our DBS system after 1 week until the electrode settles in the target. Sorry. I've been following up with him. So this video was 1 month ago. The surgery was 2 years ago. He was happy.
كمل مشي. هاي الفيديوهات إلي طبعا انت انا عارف انه انت تنزعج بس لانه لازم للمقارنة.
So on the
اليمين اضغط مع
we
اليمين.
have a very good control of the symptoms.
حرك ايديك يمين شمال.
So he told me I'm leaving the clinic, bye see you again. So again, this lady, she's a 70 years old. She's Syrian lady. She has severe rigidity. She cannot stand. She cannot walk. With the maximal dosing of carbidopa, levodopa medication, she's disabled from her Parkinson's disease. So in this patient, since she doesn't have dyskinesia, the best target again is subthalamic nucleus. As you can see, we targeted the right STN and the left STN on both sides. You can see on the coronal view, those are the two subthalamic nucleus. On the left side, it's a bit degenerated, but upon macro recording and the operation, we were sure that it was reassuring to go to this target again. So we implanted the DBS and he's walking now.
Yeah.
Again, we have to consider the musculoskeletal system, and they have to go for, sorry for the video, I don't know what's interrupting. This is the first walk for her since 7 years. So she was happy. This patient, he's a poet. He's a poet and he likes to write poetry. But he's now disabled from the severe tremor and the severe rigidity. But this patient has a cardiac and a respiratory issues. So we couldn't do deep brain stimulation for him because we cannot do GA for him. So what we did actually, I did a radio frequency. I do it under local anesthesia and the patient is awake. So we did radio frequency and ablative surgery for both the VIM thalamus and the globus pallidus internus. What I will love in those surgery that we have an immediate effect on the table and the patient is awake and interacting with us. So again, the tremor will stop immediately. You can see the electrode is implanted in the VIM thalamus now. So the patient, as you can see, he is following with us by writing letters, not on WhatsApp or emails, by texting us. So he's back to his handwriting and he's back to his hobby, which is poet. So as you can see on the MRI that we did a pallidotomy and thalatomy. We preserved all the eloquent area, the internal capsule and posterior limb or other thalamic areas that we want to preserve. So it's a very directed and targeting ablative surgery. This patient is a 41 years old. but the patient has a very intractable essential tremor that failed all the medical therapies, and it's becoming distressful in his social and mental and all other, and in his work. So he's been embarrassed to go for social activity. So what I did for him, I did a venthylamectomy for him. I left venthylamectomy. As you can see, an immediate effect intra-op. I've been following up with him since 1 year. He's 1 year, and he's doing very well, thanks God. This patient is a military man, and he has severe dystonia, and it was disabling because he couldn't again do any other activity. All his family members hold his head to feed him, and we've did a DBS for him. He's back on track. Again, in dystonia also we target the globus pallidus internus. This patient has a segmental dystonia. He cannot still his mouth, his lips. It's always moving against his will. He's keeping. He has a very swallowing disturbances. He cannot swallow properly. Those are all involuntary movement, which you can see. So we call it oromandibular dystonia. So now, after deep brain stimulation, moving his counting number, he's moving his lips voluntarily.
عبي ثمك هواء.
He can move his lips freely. He's moving his tongue freely, and his swallowing is back to normal. So this patient is a 12 years old girl. She was she has a very severe motor and vocal tics, as you can. I will show you now. She was misdiagnosed as autistic patient when she was 5 years old, and kept her family busy with her 24/7. So I'll play the video now. You can see that her motor and vocal tics are very severe.
Sorry
about that. She cannot stand still. A lot. You know, the Rett syndrome has a very bad motor and vocal tics and swearing. Some of my patients get jailed because of the swearing, but some people or the police, they don't know the fact about the disease. So this patient, we did a DBS for her. Our target will be the anteromedial globus pallidus internus. We did a deep brain stimulation. We implanted an electrode in both right and left globus pallidus internus. As you can see, after 6 months,
شوربة يا سما طيبة.
she's eating by herself. This is a 6-month video after the surgery. She wanted to become a doctor. She's back to school, actually. She was fired from school. She's back to the school and attending every activity. This
يلا
2
كيف
years
بتكتبي؟
follow-up. She started to train herself to do handwriting. She's writing her name.
برافو. سما ايش؟
بكري.
اكتبي يلا شوف.
Sorry for the video.
سما يلا كيف بتكتبي؟
As you can see, a very dramatic
برافو. سما ايش؟
controlling the motor
اكتبي يلا شوف.
power. So, some review of the lecture regarding the DBS for Tourette syndrome. As you can see, that we control the symptom of the patient between 60 to 90%. So many patients with the Tourette syndrome come with OCD. Again, recent study showed that also the OCD is controlled by the surgery. So it's promising approach for the movement disorder and the neuropsychiatric disorder. So I'm finished with my cases. Again, so in conclusion, as I showed you for the two patients of the Parkinson disease, that we have to super select the movement disorder patient, because not all the patients are eligible for surgery. Some patients, especially in the Parkinson disease, they were labeled in my clinic actually. They were labeled and scheduled for surgery, but upon thorough examination, those patients, they don't have Parkinson. They have a disease. They have Parkinson syndrome, where they share so many symptoms, but the approach will be different, because in Parkinson syndrome, there is no treatment, either medical or surgical. So we have to super select our patient. I always believe in the multidisciplinary screening and to do consultation with a neurologist, the psychiatrist, physiotherapist. Again, target selection should be correlated with the patient's signs and symptoms. For Parkinson disease, we go sometimes for STN or GPI according to the patient symptoms. Patient and education and expectation should be discussed thoroughly, because deep brain stimulation is not a cure. We control symptoms. That's what always I tell my patient. We have to always keep looking for more targets. There will be a new study, a new article I will publish that targeting the zona incerta with the STN, because they are very intimate, will get a better result, especially with tremor patient. So again, ablative surgery still blooming in terms of unfit patient, also financial issues. Patient get some concern about implantable devices in their body, but with proper patient and target selection. Thank you, and I hope I was brief in my lecture.
Thank you so much, Dr. Mazin. Actually, that was a very incredible and dazzling presentation.
Thank
And you're welcome. It just reflects that you did not just improve the quality of life of the patient, but you just gave them another hope to live their life better. You open opportunities like the young girl with Tourette. You gave her another hope, a chance to live like a normal girl at her age. So now I would like to open the floor for any questions. Please, if you have any questions or inquiries, you're more than welcome to drop it, or you can raise your hand and unmute yourself and ask Dr. Mazin directly.
Hey, don't be shy.
Actually, it's a very challenging approach, and we're not fully aware what is the mechanism of this surgery. Actually, we have some hypotheses. So again, don't be shy, because we don't have all the info regarding this disease and the management of this. So it's a new approach. It's a new technique.
Okay, I guess the audience is a little timid today. That's okay. Thank you, Doc, for the excellent presentation. And thank you, Nima, for organizing this. And we hope to keep in contact with you in the future.
Thank you. Thank you, all of you.
Okay, we'll sign off. Thank you. Oh, wait a minute. What, did someone have a question? Hello, I'm not going to leave this. If anybody has a question, let me just, I think I saw someone. Did someone want to ask something? I thought I saw Mohammed. Wait a minute, let me check in the chat.
Is it on the
Okay.
chat box?
Oh, wait a
I
minute.
can. I
Yeah,
don't see
there's
it.
one,
Yeah.
Mohammed, Bazindawa. Are you there? Yeah, okay, you can, go ahead, you can talk. Now, Mason, you can talk to him.
Hello,
Go
Where is
ahead,
the
can you hear
question?
me?
go
Yeah.
ahead, go ahead.
Dr. Mazen, in recurrent of Parkinson disease, we can make DBS more than one time or just one time only?
Actually, regarding the deep brain stimulation, we implant electrodes with a neuromodulator, like we call it generally a battery. It's a battery. So the Parkinson disease, it doesn't recur, but the symptoms are progressing. The symptoms always, it's a progressive disease. It is a degenerative disease. So the benefit of those neuromodulator that we can accommodate and program and reprogram the voltage of the device and raising the voltage of the device in a wireless fashion with the progression of the symptoms of the disease.
Okay. That means in progress of symptom, we using the DBS one time as now like that.
Yeah, we always do a reprogramming that we elevate the voltage of the DBS to accommodate
Yes.
and to control the progression of the disease.
Okay. Thank you, Dr. Maz. Thank you.
Thank you.
Thank you.
Okay, very good. Anybody else before we close?
Well, that makes me curious myself, Dr. Mazin, about what do you expect the timeline of the DPS for those patients? Like, for how long does this procedure even control their symptoms that you will not need to intervene again, or they will not need for any type of other medical modality to control their symptoms?
Actually, it's variable from patient to other, because the progression is variable from the patient. So again, I've been following up patients since like 15 years ago. We've did DBS for them, and they came back to just to replace the battery, because the previous technology, it wasn't a rechargeable battery, but the new batteries now are rechargeable in a wireless technique. So I've been following up patients since 15 years ago, and they are doing well. Some other patients, they have a very severe progression. We couldn't control symptoms either by medical or surgical intervention. So it is individualized, and it's variable from patient to other.
Very good.
Okay.
Okay, I guess we'll close now, Doc. Thank you very much, and we'll see you next time.
Thank you, all of you.
Thank you so much, Dr. Mazin. And thank
Thank
you,
you.
John.